I'm Scott Love. I'm a professor here at the University of St. Augustine. I work mostly in the FLEX program and some of the campus program. I'm a right above knee amputee, approximately 3 to 4 inches above knee center. While working as a physical therapist in Texas at a rehab center for amputee veterans, I acquired a flesh-eating bacteria that was carried over from Iraq, and it settled in my right knee. And due to the infections, I ended up with 12 surgeries in hopes of trying to fix the leg. And because the infection was so rapidly advancing, they were unable to fix it, and I chose to have elective right above knee surgery in February of 2012. So I'm 3 years status post surgery. I walk with a genium leg, and I'm very active in sports. And I'm very interested in the taping methods that will be displayed today by Steve in hopes of reducing phantom pain and any other benefits it may afford me.
What would you rate your phantom pain at?
Today, and of the foot that you can't see, my pain right now is probably, we'll go with like a 7 to an 8. And it feels like the right lateral side of my foot is being squeezed. And I mentioned this in class. It feels like the right lateral side of my foot is being squeezed in a vise. And so I would call it a clamping type pain.
Steve Middleton from RockTape. So today we're going to try some different taping techniques working with the amputee population. What we'll start with to begin with is going to be immediately post-surgical or post-amputation to work on edema and swelling control, to try to get them into a permanent prosthesis quicker. And then from there, after the 6-week, 7-week mark, once the incision sites have healed, then we can progress to scar tissue mobilization as well, with the hopes of cutting down on pain and adhesion formation. So then that'll be the next technique that we demonstrate. So while Dr. Love finishes up, I'm just going to do a quick measurement. With lymphatic drainage or edema control, we're going to do what's called a fan technique. So I'm going to measure the amount that I need, and then I take and double that, because we're actually going to apply at least 2 applications with that. So with this piece that I have doubled over, this open end, I'm going to round the ends. We always want to round the ends because the square corners will catch on clothing and come off quicker. Now the creased end, I'm going to cut that in half. I'm going to go down to it leaves about a 2-inch base. From there, the 2 tails I'm going to cut into halves as well, so that we're going to end up with 4 total tails, which will make our fan application. Once I have those cut, I just slide my scissors in and cut it in half. It just saves time, because then you're technically only spending time cutting 1, but you're getting 2 out of it. So whenever we're taping for edema, swelling of any type, longer when they get into the rehab process, you can still do lymphatic drainage beforehand, any type of massage beforehand, and afterwards you can still do the typical compression dressings, things of that nature. As we apply the end, I tend to take, and I'll tear each one of those off. It's just easier to work with 4 separate strips than trying to lay them down and spread them out from there. So with lymphatic drainage or edema taping, we're always going to put our base where we're going to draw the fluid to. Now, if you want, you can take it all the way up to the inguinal lymph nodes, but typically just taking it somewhere away from the joint helps pull the fluid out from there. So I put the base down with no tension through that. You don't ever want to put tension through the base, because that will pull on the skin and cause shearing, which can cause blistering. From there, I'm just going to lay the tape down as I pull the backing off, kind of fanning it out, trying to cover as much space as possible to decompress the tissues. Again, the big thing with this, you're going to work with what your patient presents with. So you won't go down over bandaging or anything like that, making sure you're making contact with the skin the whole time. Once the tape's applied, we want to rub it to activate it because the adhesive is heat activated. Then our second application, we're going to take and overlap that at an angle. So again, I'm taking my base up proximal. And again, just laying the towels down as I pull the backing off. We always want to end tape on skin. Even though you can cross over the tape, it doesn't end up sticking as well to itself, especially if you're talking about the end point. And again, we'll rub that to activate it. Now that's a basic application. If we were taping him clinically, we could apply multiple of those around the residual limb to get the swelling and inflammation down quicker as well. Since this is just demonstration purposes, we're going to remove this now. We always want to stabilize the skin and pull the tape away from the skin in the direction of hair growth. So far, so good?
Yeah.
Okay. Questions, comments, concerns so far?
That was my question. I was wondering if it's appropriate for me to ask questions while you're going.
Oh, yeah.
Okay. So that's why I was just wondering. So when you fan that out, what is the process that's going to draw the lymph up towards the more proximal portion, the heavier portion?
There is a recoil property to this tape.
Oh, so the tape itself, when you activate it.
Yeah, it's not like regular tape that's just woven together. This stretches. RockTape stretches a lot more than the other tapes on the market. So most of the other tapes stretch about 130% of their normal length. This stretches 180%. And how it works most effectively is the technique originally developed by Kinesiology, which is a fascial wave pattern. So if you look at the back of the tape, and it's the recoil property that we can use to mobilize tissue or fluid. So if I put this down and I stretch that, when I let go, it's going to always recoil back to wherever that base is. So by putting the bases more proximally, then it pulls the fluid and tissue towards it.
With those woven patterns on the bottom, is that what you pull it out and stretch it? Is that the kind of the application process that's going to pull the fluid? Is that what that's for, those lines on the base of the tape?
Correct. And by putting the base with no tension, then everything pulls back to that. So you can angle and direct fluid wherever you want, or tissue, if we're talking about fascial or skin mobilization, wherever you want it to go as well.
So you're saying this would be appropriate status post amputation day 1, day 2, something like that?
Day 1, almost immediately after amputation, to get the swelling down, and a lot of the pain immediately after any type of surgery or injury for that matter is going to come from swelling around the area, putting pressure on the mechano and nociceptors.
How far down have you ever taken it? Have you ever had experience or not yet? But I know that like most amputees have a bulbous end when they're done, which is basically just fluid, So do you ever take it down into that, or you haven't had quite the experience yet?
I haven't had that experience. The big thing is going to be your incision guideline. So once the site's healed, I could theoretically take that all the way down. For demonstration purposes, we're going with more of a immediately post-op, where you would have bandaging of some type. But at your case, or even 2.5 years ago, we could easily take that down and wrap it around the end as well.
So once the incision's healed, and you're still going to have swelling for like a year and a half afterwards, you can take it down over the residual limb, the end of the residual limb, and then fan it back. Well, start here, then fan it down over the residual limb.
Correct.
Okay.
Yep.
That was my question.
Okay.
Okay, Steve, with lymphatic drainage, how much are you pulling?
It's just taper off tension, so I'm not actually pulling the tape, I'm just laying it down as I pull the backing off, because regardless of what brand of tape you buy, it's pre-stretched on the roll, so there's about 15 to 20% tension on the roll. And for most applications, that's as much tension as you need with it. Okay. There are some other techniques which we're actually getting ready to go into with the scar tissue mobilization, where we're going to put a little more tension in it as well to break down the skin.
You use cryotherapy with it?
You can. I don't typically, because the adhesive's heat activated, so it makes it come off quicker. So if you were going to do cryotherapy with it, you do that first, and then let the limb re-warm, and then you can put the application on after that.
Are there any other tapes in the market? I mean, I don't know if anybody saw it, but it has that woven pattern on the bottom side. Any other tapes in the market have that?
Kinesiology was the original. They've actually been around since 1974. It was developed by a Japanese chiropractor, and now I think there's probably about 20 different tape manufacturers, and they all go with the same woven pattern. And Kinesiology's recently released a fingerprint one that has a smaller wave pattern to it as well, that
Okay.
they think is now more beneficial.
It's a lot smaller than the wave pattern we saw on the
Yeah, and it basically looks like the wave of your fingerprints. It's
Yeah,
so small.
I can picture that being a little smaller. Yeah.
Yeah.
Right.
So if we're talking about scar tissue mobilization, in Dr. Love's case, the biggest incision and probably the cleanest one to work on, he has a couple through here. Probably there, and is that where they sewed the flap?
Yeah, that's got the flap over there. Yeah.
Is that an area that you have had pain in the past?
Not usually in the distal end, but I do get itchiness there, which
Okay.
is a phantom sensation. Of all the places that gets itchy, it's usually right here, right where the incision is.
So with scar tissue mobilization, you can do a couple things with that. One, because the scar tends to tension all the tissue that connects into it. So in this particular case, it could tension the remaining of the quads, which could cause a hip flexor contracture, or if it were more posteriorly, then it could tension the hamstrings and cause a hip extension contracture, which would be much more rare. So in this particular case, I'm going to take and cut about 3 inches of tape. Again, I'm folding that over then, rounding the ends. The folded end, I'm going to cut once in half. I'm going to fold that over and round those ends. So I make 2 what's called Y strips, where there's a base with 2 tails coming off of it. Now in this particular case, again, I'm going to break the tails loose from the base. With this, again, we're trying to mobilize tissue. So I'm going to go, in this particular case, since it's a transverse incision, I'm going to go inferior to it and apply my base. It's okay to put down?
Sure.
Okay. And then from there, again, I'm going to fan these out. Now I'm going to put tension all the way through these because I want it to pull on the incision to work on breaking the scar tissue down. So since I'm putting more tension through this, I always want to stabilize my base so I'm not pulling on that tissue, which could cause shearing and cause blistering. So again, stabilizing, I'm going to take about 50% tension up and ending that on the scar. Same thing, stabilizing, about 50% tension going up, ending on the scar. With my other end, in this particular case, I'm going to go on the superior portion. No tension through my base. Again, stabilizing it. About 50% tension, making sure not to wrinkle it. Again, ending on the incision side. So by alternating them back and forth, it's kind of making a zipper approach to it. And what that's going to do, this piece is going to pull that scar tissue up while this one pulls it down. Now I may take a picture of this and then next time alter it so that the more lateral portion's pulling up first and the more medial portion's pulling down. So over top of all of this, we're going to do what's called a spacing technique, which is a little bit different application. So again, I'm going to cut about 5 inches of tape. I'm going to fold it to around my ends. But this time what I'm going to do, I'm going to tear it in half. And what that lets me do is it opens the center up. From there I'm going to put about 50% tension. And then that's going to go right over the incision site with no tension on the end. So I'm just pulling the backing off, laying that flat. And again, I'd rub all of that to activate it if it is something we're going to leave on. What the spacing technique is going to do is it's going to act like a tent to pop up the different layers of tissue. So it's going to, again, lift the skin up off the superficial fascia to increase blood flow by decompressing the superficial capillary beds. It'll lift the superficial fascia up off the deep fascia to decompress the nociceptors and mechanoreceptors to help with pain. And it'll lift the deep fascia up off the muscle, which will help with lymphatic drainage as well as increasing muscle contraction in that area as well. Is that an application you want to leave on?
We can't. I just had a question. So in other words, this portion pulls the scar tissue superior.
Mm-hmm.
This portion pulls it inferior. And then you said something about the tenting process, and I wanted to catch on that.
The piece that goes across is a spacing technique, and that's the one that acts as the tenting to decompress all the tissues underneath it.
Okay. So in other words, you have a superior pull, inferior pull, and then like an anterior pull, basically, that allows, and it's actually separating all the tissues in your hopes of decreasing the nociceptors.
Correct.
Okay. Because, yeah, I'd be interested in keeping that on, because obviously the nociceptors in my residual limb are what's causing the phantom pain.
Mm-hmm.
Because when they did my surgery, they took the sciatic nerve and they, we talked about in class, they cut it with a scalpel under tension,
Mm-hmm.
and they branched it. So in other words, they took the tibial and the peroneal branches and wound one around and split it, and wound one around and split it, and trying to decrease as much phantom pain as possible.
Okay.
So, and a lot of times people don't get a good surgical cut. They might get a guillotine cut, which basically the surgeon goes in and just cuts it off, where this one was done better. So I would be interested in keeping that on if it's going to pull up the fascia, like you mentioned, in a deep area, and maybe decrease the nociceptor sensation. So that'd be interesting to keep on.
Okay. Amputees present a lot of times with weak gluteus medius on the affected side, which can lead to a hip hiking, as we see here. What tends to happen is the gluteus medius should do a posterior translation on the femoral head to help the femur move into flexion, but when that doesn't happen, they tend to compensate with the hip hiking through the quadratus lumborum. So we're going to have him come back to center here, and we're going to give him a chair to use for support. We're going to keep you facing that way.
Can you explain that one more time for you? You say that the gluteus medius, when I'm walking, with natural gait, is supposed to pull the femoral head posteriorly.
It should do a slight posterior glide, so you're able to bring the femur up, and it clears the AIIS.
Yeah, okay.
Yeah. And then when that doesn't happen, your brain knows that your legs should go higher. So if you can only get to about right here, then you tend to compensate by hiking to go farther.
Okay.
So I'm going to have you stand right here facing that way for me.
Okay.
Now with this particular case, because it's larger muscles that we're covering, we're going to use a 4-inch tape. I'm going to measure from his lower ribs down to approximately his greater trochanter.
So you're going to go like P11 all the way down to the greater trochanter?
Correct.
Wow. That's a long strip. So are you trying to take the quadratus lumborum out of the picture on this?
Correct.
Okay.
This is one of the force couples in the body that can compensate for each other. You going to take your shirt off?
Mm-hmm.
So I'm going to put my base up on his lower ribs. So I'm going for the insertion of the quadratus lumborum. So there's some thought that by going insertion to the origin, we'll get the muscle to relax. And then once we get to the iliac crest and go down, we'll actually be going origin to insertion of the gluteus medius to facilitate it contracting. We always want to put the tissue on as much stretch as possible. That's where the chair is going to come in. I'm just going to have Dr. Love lean to his left for me so that he puts his hand on the chair. I'm going to have him do a little more. Perfect. So from there, again, it's just paper off tension coming down to the iliac crest.
So this is insertion to origin, correct?
Correct.
Because quadratus is iliac crest up until the lower ribs?
Correct. And can I take my hand up?
Sure.
Okay. So then from there, I'm just going to feed the paper through. Since we don't want to overexpose our patient, I'm going to feed the paper through. I'm going to have him take a slight step forward with his right leg. So we're going into flexion, slight adduction, and slight internal rotation, again to stretch the gluteus medius. And then with this, the paper that fed through, I'm just going to pull and angle that towards the greater trochanter. And what that will allow me to do is lay the tape down without having to overexpose our patient.
And this is the lower half of the application for the glute medius.
Correct.
Okay. The glute medius ends up at the lesser trochanter and starts something piriformis. Where does the glute medius start?
Piriformis runs, glute medius runs from the iliac crest to the greater trochanter. In this particular case, I measured a little too long, so I don't want to end down on his prosthesis device. I want to end on skin, so just trimming that. It's always better, especially when applying long strips like this, to be a little long than to be short with it. So we go ahead and bring his shirt down now. And whenever Dr. Love is ready, we'll have him go ahead and walk again.
Looks good.
You're not hiking as much. What does it feel like? Yeah, you don't have the lateral trunk sway now like you did.
I didn't do that yet. I feel like my trunk is more erect.
So we're going to leave the application that we just applied on. But one of the other big issues with amputee patients is phantom pain. And one thing we're going to try in this particular case is to do a decompression of the central nervous system and the peripheral nerve roots to try to address the phantom pain. It's been used successfully in patients with fibromyalgia and reflex sympathetic disorder or complex regional pain syndrome. So in this case, what I'm going to do, in a non-amputee patient, I tend to put them in a quadruped position, so on their hands and knees, and I have them go into the yoga pose, the angry cat. So it's a total spinal flexion. But in this particular case, we're going to have better stability sitting. So I'm going to measure from bottom of the sacrum up to about T1.
Are you going to put this on the unilateral side or cover the spinous process area?
Well, with this, it's going to cover the spinous process with it.
So you're trying to catch both sides of the nerve roots coming out?
Correct.
Okay. And what's the idea behind that? The tape does what to the fascia to desensitize the nerve roots?
It's going to be a similar application to the spacing technique we applied to the incision. So again, it's just looking to tint and lift all the tissues up.
Tenting process. Okay.
So once I've measured that, I'm going to again tear it in the center. I'm going to open that up. So I'm leaving about 2 inches on each end for my bases that we won't put tension to. And from there, I'm just going to have him in a seated position, going into as much flexion as he can get, including the neck. I'm going to go to about 50% tension with that. I'm going right over the spinous process, going up onto the neck, but I tend not to go all the way up on the neck. You can get blistering there because the neck's so mobile. No tension on that end, and no tension on that end. And again, we'll rub that to activate it. Okay, go ahead and come up
So
forward.
when I come up into extension, is that where the tenting process takes place?
Correct. It's going to lift up all the skin.
I can actually feel it up the skin, that's what I was wondering.
And a lot of times, you can't see it as much here as you can over here, but when you tape an area where there's tightness or swelling or things of that nature, you'll get convolutions in the tape, which kind of looks like wrinkling, but wrinkling tends to occur more when the tape sticks to itself as you're lying it down, or you've not laid it down evenly like that tends to happen with white athletic tape. But this is just another indication that it's lifting up tissue in that area. And then we'll follow up to see what his pain level is like over the next couple of days.
I'm concentrating right now because since you put that on, I feel a different sensation in my right fifth. Well, I don't want to say my fifth met, but it's not there. But my supposed right fifth met, it used to go, and this is hard to explain because the foot's not there, but you understand what I'm saying. I used to have burning out to the end of the toe, and now it seems like it's back about the medial portion of the foot.
Okay.
So, and more of a phantom sensation decrease right now.
Okay,
So,
great.
which is kind of cool, because I'm very aware of where my foot supposedly hurts or, has sensation. But just in that area right now, it's not in the toe anymore, or the toe that's not there.
Let's try one more thing.
Okay.
With the lateral foot being L4, let's be more targeted with it since that's where most of your symptoms are. So let's come over to sacrum L5, L4. So we're going to do a spacing technique between the L4 and L5 vertebrae, hitting that L4 nerve root. So again, rounding my ends, we're going to go again with a spacing technique, so tearing that in the center, opening that up. 50% tension. Again, I'm going to palpate sacrum, L5, L4. So going between those two, 50% tension. No tension on the ends. And again, rubbing to activate. And now when we have him come up, did that cause any sensation change along that dermatome?
Concentrate a little bit because I really have to think about this. It is more, still not into the fifth phalange or the metatarsal. It's back about, if I said, if I had the foot maybe a couple inches in front of the malleoli, the lateral malleoli.
After the application of the second?
Yes, and I feel it more on the top and very little on the bottom of the foot.
Okay.
So there's definitely a change in it. The big thing is that people knew about amputations is how debilitating phantom pain can be at night when you take the residual limb off, and when you take your prosthetic limb off. So it'll be kind of interesting to see how that is when I walk all day and take my prosthetic limb off. That's when my phantom pain is the worst.
Okay.
And sometimes it's debilitating to the point where you use Neurontin to try to mask the pain. But so this, from my experience, it takes before you keep this on for a couple days.
Can't take and turn your right.
Oh, yeah. From my experience, from before you can keep this tape on for a couple days.
All the standard speech from all the companies is 3 to 5 days.
Okay.
I tend to go more based on what you're feeling with it. If you start feeling itching, burning under it, it's time to take it off. If you feel it in a couple hours, then it may be an allergic reaction to it, and it's definitely time to take it off. With extensive wear, especially with as active as you are and the humidity here in Florida, as you sweat, the tape's waterproof, so you can shower with it on, swim with it on, whatever you want to do. But as you sweat, the water component will pass through, but the salt component crystallizes under the tape, and then that's what will start irritating the skin. So I found that tends to work better than just a rigid 3 to 5 days and you take it off. Most of my patients wear it at least a week. I have a lot of patients who travel internationally, so they may leave it on for 2 to 3 weeks at a time while they're gone. The current record that I have personally has been 29 days. I've had a patient leave it on.
So durability that long? That's a pretty long time for durability. Yeah. And so to get the true idea of whether it's decreasing phantom pain, because mine fluctuates depending on whether my prosthetic limb is off. So keeping it on a couple of days would definitely be beneficial to chart your pain levels.
Correct, and each day that it's on, the pain should be a little bit better. Once it comes off, the pain tends to come back a little bit, but it doesn't tend to be as bad as what it was before taking.
Okay. That'll give me something to start charting. Maybe I'm going to write it down.
Okay, sounds great.
Sounds good.
Okay, questions, comments, concerns from anyone? Okay, thanks so much.